Okay, thank you. First of all, I want to thank Dr. Joseph All and also the Hong Kong Precision Oncology Society for inviting me to give us this talk about the tumor treating fields, or TTF or TT fields, the new efficacious therapeutic modalities for both recurrent and the newly diagnosed glioblastoma, or GBM for short. This is my financial disclosures. Mostly it's for research, clinical trials in our institution. And also the disclaimer. So this is the topic of my talk today. Mechanism of action of TTF, preclinical data. Both of those two has been covered, I'm sure, mostly by Dr. Tressa McGranahan yesterday, and also by Dr. Giovanni Sarasoli yesterday on mesothelioma. So I will go over that briefly as well. And also I will cover the brain tumor clinical trials using TTF, EF11 and EF14. And then we'll talk about the practical usage of TTF in terms of generating the array maps and also application of the device to patient. And also we'll cover the real world usage of TTF in USA. We call a PRIDE data set, and also EF19, which is not published yet for the EF19 data. And also I will present some of our patient examples to share with you. The last topic is side effects of TTF and the management. So what is TTF? This is a novel, portable, electric device for therapy of glioblastoma. As you can see, this carries an intermediate frequency, about 200 kilohertz, alternating electricity in two pairs of arrays. Physically speaking, it's two pairs of capacitors. So the tumor is in the center of that, and then the current interferes with the tumor pre-programmed mitosis. And there are two generations already. The panel A is generation 1 or first generation, and the panel B is the current generation, which is a lot lighter and slim and easy to be portable for patient. So as you're all aware of, TTF interfere with cell mitosis and cell cytokinesis. So this was demonstrated by in vitro studies, and this device has been frequently used in laboratories, which is mimic the human TTF. It's called an in vitro, produced by Novocure company, and can be shared with laboratories who apply for that usage in laboratories for cell cultures. Through that experimentation, it's been demonstrated that cells in the electric field were not able to divide normally. Like here, the cell would be dividing with the chromosomes at a metaphase, and in the equator would separate by the microtubules. But in the electric field, in the presence of electric field, such process is altered and slowed, and eventually the tumor cells entering apoptosis or cell death. So this is another example of that, which actually have a video online of a Novocure website. So the normal cells will be dividing 2 hours, 3 hours, but in the TTF electric field, the cell was not able to divide as was programmed to do so. So at the 30 minutes and 60 minutes, as you can see, the cells disintegrated in the presence of TTF. So how do we use it in clinical application? Number one is we had to measure the tumor location in regards to the brain and the scalp landmarks using the latest MRI. usually it's before the application of the array, and obviously the latest MRI, and after surgery, usually use a tumor progression or just the post-op MRI for newly diagnosed GBM. So we measure the tumor location in reference of the scalp landmarks, and then entering the measurements to the NovoTel. This is a software developed by NovoCure company, and all the certified physicians has access to this application. And then once we enter those measurements, the software allows us to print out an array map. And this array map is guiding the technicians of NovoCure company and also us and also patients for placement of the arrays on the scalp. Obviously, it allows flexibility for movement, for shifting this array location, as you will see next. And then the placement of the TTF on patient's shaved scalp. Usually in my clinic, for better education, and this also can be done in patient's home. So this is an example of a tumor location. As you can see, the enhancing tumor at the left thalamus on the horizontal view or axial view of the MRI. So we can measure that AP length, and then left and the right length, and then you have the midline. So those are landmarks. And then the tumor have the proximal to this, to the anterior, and the proximal to the left side of the patient's scalp. Then entering those measurements. So the next is coronal view. Same thing here. So you have the measurements here, and then you have the tumor location. So once you have those measurements, so the machine will know where in relevance of the tumor location to the brain landmarks. So we're entering those measurements into the NovoTel software, and then we're able to print out, NovoTel generate a array map. So we are able to print this out and then give to patient and give to NovoCure technicians as a guidance for placement. Okay, what's the evidence of TTF in clinical usage for GBM patient? There are two famous trials, as most of you have heard about it. Now, one is EF11 for recurrent GBM. The second one is EF14 for newly diagnosed GBM. So this is a paper that's been published in 2012 by Stoop and colleagues studying the randomized open label phase 3 clinical trials of novel TTF versus best standard of care therapies for recurrent glioblastoma. 120 patients in one arm for the novel TTF, and then 117 for the best physician choice arm as active control was randomized to each arm. Hello? Any questions? Okay, I'm just going to continue. So the patient for the TTF, they required to use about 20 hours per day or 18 hours to 20 hours out of 4 weeks average. That is 18 hours to 20 hours per day in the 4 weeks average. So that's the requirement for the TTF usage. And then the control arm can be the physician's choice, treating physician's best choice. It can be anyone. And those are the chemotherapies patients have been given. And this is a summary of the treatment drugs that's been received for the control arm. For the TTF arm, it's just monotherapy with TTF. And as you can see on the physician's choice, all the chemos we are familiar with are used in different percentage of those recurrent patients, and including bevacizumab. And then the most common is a nitrosourea / PCV, about 33%. And also platinum-based chemo drugs, temozolomide, CPT11, all of those has been used. So The results is assessed by investigators using MRI per McDonald's criteria. So partial response in the novel TTF arm 11, and the complete response is 3. In the physician's choice group, partial response is 7, complete response is 0. If the trial teased out those patients that did not follow the protocol, in other words, they had to be treated at least 1 month worth of the TTF as required by the protocol. If they are not, they were excluded. So we call it a per protocol population. If that's the case, this percentage of response is similar still. The PR is 11, CR is 3, and then the physician choice arm is 7 and 0 respectively. But the overall survival curve is better. But that's more for a reference. The trial is used for intent to treat population. So this is the results for that. For the overall survival group, as you see, the two curves, the blue and the red, are pretty much overlapping. And the blue is represent monotherapy with TTF, and the red is the best physician choices. The number is overall survival 6.6 months in the TTF group versus 6.0 months for the best physician chosen choice group. No statistical difference. For the progression-free survival, similar. 6 months of progression-free survival, about 21.4 months for TTF group, and 15.1 months for the control group. Again, statistically similar. So this demonstrating that the monotherapy with TTF versus best physician chosen choices are similar or comparable, but the side effects is a lot infrequent in the monotherapy group. Mostly is the skin irritation from the array contact. We call it contact dermatitis. So based on that data, the FDA in the USA approved that for recurrent GBM. Then the next trial was carried out at the same, around that time period, called an EF14. That's maintenance therapies with tumor treating fields plus temozolomide versus temozolomide alone for glioblastoma. So this is basically the standard of care of concurrent radiation with temozolomide versus standard of care plus TTF for newly diagnosed GBM. And 695 patients was randomized to two groups. It's 1:2 ratio of randomization. And our hospital, both at Tufts and also subsequently in UT at Houston, were participants of this trial. So in the trial requirements or pre-planned interim analysis, the results was tabulated and then it's shown like this. The progression-free survival is 7.1 months for the treatment arm and then 4.0 months for the control arm or the standard of care arm. And it's like a significant difference in the two curves. And then this is about 315 patients total. So it's about halfway. And then for overall survival, the TTF with temozolomide is providing overall survival of 20.5 months versus 15.6 months of the control arm or the standard of care arm with temozolomide alone. So because of this interim data results, the data monitoring board decided that this trial is demonstrating the superiority of the combination of TTF with standard of care. So continuation of this trial is not ethical anymore. Because of that, so the trial is unblinded, and then the control arm patients is allowed to cross over if they choose so. So this is a subsequent paper of all the patients finish their treatment and then continue follow-up until either they passed away or the last censor of their clinical status. So total of 695 patients. And then again, this both papers published in JAMA. One is 2015, and the complete data is published in 2017. So this complete data confirmed the interim analysis results, specifically the median progression-free survival, 6.7 months for the treatment arm, and then 4.0 months for the control arm or the standard of care arm. And the median overall survival is 20.9 months for the treatment arm, and then 16.0 months for the standard of care arm. So there's a clear difference in overall survival as well as progression-free survival. So based on this data, FDA approved TTF for newly diagnosed GBM. And the side effects, again, is the skin irritation, no systemic side effects. Confirmed the observation by EF11. Subsequent analysis of the EF14 data, looking for compliance versus overall survival as a prognostic factor. This paper is published in JNO in 2019. So this is the data. I'm going to go over this slowly because it's a complicated slides here. So this is for the progression-free, for this post hoc analysis for people with a high compliance, that means 90 to 100% compliance, 43 subjects in this group. Obviously, this is in the treatment arm of the EF14. And then versus the TMZ, that's the standard of care arm. So this is the treatment arm of 43 patients. And this is a progression-free survival of 229 patients. As you can see, there's a clear difference. And then the median progression-free survival is 8.2 months. So it's a lot better than the whole group together. For the overall survival, the same situation. So the 43 patients, the overall survival is 24.9 months. So better than the 20.9 months of the whole group of the treatment arm. So as you can see, the overall survival difference is clearly statistically significant. And also for measurements of survival rate with years, 1 year, 2 years, 3 years, and 4 years, and 5 years, the treatment arm patients always outperform the standard of care group. And this is a 43 patients that with a high compliance. As you can see, at 5 years, about 30% of patients are still alive. That's very, very significant and remarkable. Really telling us that the more we use that TTF, the better survival benefit patient would draw from that. So then, per FDA requirements, there is a post-marketing registration studies. So this there's 2 studies of that. One is called a PRIDE data, which is a patient registry data set from October 2011 to November 2013 for all recurrent GBM, because the FDA approval was 2009, and the initial treatment was just beginning. So the Novocure did not register all the patients until October 10th. They register all the patients that start using the device. So about 457 patients was registered in that category. The patient they had to use Optune either alone or with any chemotherapy that's treating physician chose. And it spans 91 US cancer centers. So this is the result. I understand it's not a rigorous scientifically for this comparison, but this mostly to give a signal of this group. That is the PRIDE data, 457 patients and recurrent GBM. And this is this curve, the blue curve or the light blue curve, overall survival is 9.6 months from the time of recurrence. And then the versus the EF11 TTF treatment group, 6.6 months, as we just talked about. And also the other group is the best physician chosen choice, which is 6.0 months overall survival. So those two groups are together pretty much similar or comparable, but the PRIDE data group clearly better. As I said, it's not scientifically vigorous to compare, but it gives us a signal that even with the post-marketing treatment, there is a survival benefit of opportune usage. And also it confirms another observation from the extension of the EF14 and subgroup analysis. Better compliance translate to better outcome. Again, the side effect from the PRIDE data showing the similar observation, scalp irritation only, no systemic side effects from the usage of TTF. So let's move forward to the EF19. And this is, again, the post-approval registry studies of tumor treating fields in recurrent GBM. But this is monotherapy with the TTF only. So the total recruitment period is 24 months. And then the follow-up period, at least 12 months for the total 192 patients. And then the age is 22 and above, and the KPS is 70 and above. So it's a prospective, non-randomized, open-label, post-approval registration studies of TTF treatment of GBM, recurrent GBM. So all the patients have a standard of care, maximum debulking surgery, if possible, followed by 60-grade or above 60-grade radiation with concurrent temozolomide, and followed by cyclic temozolomide for 6 months or until disease progression. And then the progression is measured by MRI with McDonald's criteria. All patients with the TTF treatment is a standard FDA approval guidelines, 20 kilohertz, 18 hours per day in a 4 weeks average. Obviously, not all patients are receiving the full planned dosage of RT, TMZs, or TTF. Patient with suspected pseudoprogression or radiation necrosis was excluded. The primary endpoint of the EF19 is overall survival. Secondary endpoints are overall survival for patient per protocol population and time to treatment failure, as well as adverse events. The comparator group is the EF11, the control arm, the best physician chosen choice group. Again, this is as a reference, is not part of the trial. So this is the patient baseline characteristics for the TTF and EF19 group is listed here. And I highlighted here, make it different because I want to make sure for the audience that this is not a in-trial comparison. This is a reference of the EF11 best standard of care group, which you already know, the 117 patient as a comparator. And the same thing here. So this is obviously patients have received the previous chemotherapies and the steroid usage, anticonvulsant usage, all those are tabulated. And biopsy, only partial resection, gross total resection, and also MGMT status. So all those are tabulated here. So the results is following like this. The median overall survival for the EF19 group is 7.4 months versus 6.4 months. Actually, I think it's 6.0 months for the EF11, the control group. But even for the versus 6.4 months, it's still better. And also the overall survival is, even though looks a little bit better, but statistically is similar. So in other words, there is a non-inferiority as the original goal is achieved. In the per population, in the per protocol population, the mean overall survival for the TTF is 8.1 months. So it's statistically significant, even compared to 6.4 months. And the median time to treatment failure was longer in the TTF field group versus the BSC group, which is 3.3 months versus 1.6 months. And the average usage of the TTF in the first 6 months is tabulated as well. About 43% of the patient was able to achieve 75% and better. In terms of survival rate of the EF-19, 6 months, 12 months, 15 months, and 18 months. As you can see, the blue bar represents TTF group, the red bar represents the BSC EF11 control group. And in every 4 segments of time intervals, the TTF group outperformed the BSC group. And as you can see, in the first 3 segments, actually it's statistically significant. But at 18 months, it's comparable, but still better graphically. So in other words, it's not worse. And then the side effects, again, confirm that what been demonstrated in the prior data in the EF11 and the EF14 data, that it's a skin and the subcutaneous tissue disorder that's observed most common in the TTF group. Obviously, those patients may have some other side effects, as you see, but the most common is the skin side effects. And the skin side effects is not severe enough to cause discontinuation of participation of the trial. And then most of them are reversible if take some time off using the TTF. So in conclusion of the EF19, the post-approval studies confirmed the safety and the efficacy that's observed from the EF11 and supporting the usage of TTF as a monotherapy for recurrent GBM. The second point is TTF treatment demonstrating a better toxicity profile and a comparable efficacy outcome to those of systemic treatment in the EF11 trial. So now let's talk about how to introduce TTF to patients. As you all know, this is, even though there's no side effects except the skin or the scalp irritation, it's really labor intensive and also disfiguring. That's especially for women. Shaving hair is a big challenge. So, but from a medical perspective, as we see, it's definitely beneficial. So how to discuss that with patients? So what I do over the past 10 years or so is I introduce this concept of TTF to patients when the diagnosis of GBM is confirmed. I show them the model, show them the basic principle, the usage, the side effects. I do not anticipate patient going to sign up right away because it's the introduction of the concept. Some patients willing to take it as recommended, and other patients do not. So I obviously respect patients' choice, but my recommendation is clear. And then I introduce that at the GBM recurrence, because we're gonna have to share the alternative therapies to patients as the tumor progresses, either surgery or gamma knife or laser or alternative chemotherapies such as bevacizumab or CCNU or combination of those above. So at this point, I introduce the TTF again if patient is rethink about this as another option. We have a monthly tumor support group, which changed since the COVID-19 to a web-based. Before that, we have face-to-face in our conference room of the hospital. So patients get together 6 p.m. to 8 p.m. once a month. And I have a specific physician talking about a topic, let's say pathology, radiation oncology, or molecular biology, or clinical trials, or nutrition. So those different topics patients are interested, we share that about 30 minutes or 45 minutes. And then afterwards, patients share their experience with each other and learn from each other. So some patients wear the TTF during the tumor support group. Another patient would ask them their experience, so they learn from each other. And I think that's actually very helpful as well. And the fourth point is physicians' enthusiasm about the TTF is very important. If physician is not believe this device, and that patient can tell and family can tell, and then they probably not enthusiastic about the TTF either. But if physicians are very enthusiastic about this device and then share the data with enthusiasm, and patients more likely to take that. And also they're more likely to be compliant and better. And as we already know, better compliance translates to better outcome. And also the full education about the device usage and the side effects management are very important, as you can imagine. If patients have side effects and then they keep using it and causing ulcers of the scalp and sometimes causing infection, and there will obviously have to stop the TTF altogether. So that's more dangerous. So the close follow-up is very important as well, and the management. So let me share some of the patient examples with you from my practice, both from Boston, and then I moved to Houston in 2010. So this patient is a 50-year-old pilot, actually from Air Canada, from Quebec, Montreal. He went to Boston to participate to this trial of EF14 at that time, 2009. So his diagnosis of GBM was in 2009, March 2009. That's the picture that's before the diagnosis. And this is a horizontal view with contrast. And this is a flare MRI and the horizontal view as well. This is post-op. And then November, she had a tumor progression, as you can see. And then post-op, that's January 2011. And so he was on the normal TTF, and then he's actually IDH1. At the time, initially, we did not know, we did not do the test at that time, 2009. So later on, we did that. It's IDH mutant, and the MGMT methylated during the first surgery. But after the second surgery, it's not methylated anymore. So he had been using the TTF after the 12 months of, we're using 12 months for temozolomide. And after 12 months, and he using the TTF only. So from the 2016 all the way to 2019, 2020, and he's still alive, this person. So I'm going to show you some more scans next. So this is 2019. So that's a scan, as you see, the left frontal, and with a little bit of flare change, which may not be seen well on this exposure, but there's no abnormal enhancement. So he has been stable clinically, and he's not able to work, but he's pretty much normal as an individual. And he travels actually to Hong Kong, to many places internationally. Unfortunately, routine follow-up, this is August 4, 2020, showed this new enhancing spot. So he actually operated again by his original surgeon in Quebec, just done recently, and he did it well after the surgery. So this is the example of TTF really helping this patient for over 11 years as if now. Even though he has disease progression, but he really a long-term survival from many different angles or by whatever standard we use, even though he's IDH1 mutant and initially MGMT methylated, so he belonged to the better prognostic group. But we all know, even we have IDH1 mutant and MGMT methylated patients, they don't live for 10 years. Okay, so let's keep moving forward. What I've been doing since I've been practicing neuro-oncology because of devastating disease of GBM, once it's progressive with bevacizumab, nothing stops it. It's still the current status as of now. So it's very aggressive once they progressed on bevacizumab. So I started using combinations of all those FDA approved individually, but together is not. So I have some patient that's doing well clinically, especially the bone marrow functions well. So I'm using this together for modalities for selective patient, and obviously with close follow-up. And I share the challenges we face, and patient agreed to be aggressive during recurrent. So this is for recurrent GBM. I'm using this regimen. We call it triple chemotherapy plus Optune for selective patient and with close follow-up. So we actually summarize our data because patient, other investigators would think this is a very aggressive approach. By doing that, might harm patient, which obviously is a risk. And I'm keeping that fully in my mind. That's why I follow them very closely. So this is the data we have 18 patients that's use the triple chemotherapy plus TTF. And then this is temozolomide, as you can see, this is 19 cycles. And so this is this group is TTF plus any other chemo. So you use serving as a control in a way, but this is all retrospective data, so it's not really a trial. But to give us a sense of safety and also maybe a signal of efficacy. As you can see, there is the overall survival is 32.5 months for this 18 patients. And then the T plus any chemos is 17.8 months. It's comparable to the standard of care situation. And then the side effects, which is true, there is an elevated frequency of thrombocytopenia. The platelet number drops more frequently. So what I've been doing is, if they have a low platelet, I just hold the bevacizumab, actually not hold the CPT-11, and then continue the bevacizumab. Obviously, if it's too low, let's say less than 30,000, I hold everything, and with close follow-up with CBCs. And then when they recovered, we resume with a reduced dosage of CPT-11 or temozolomide. Or maybe I just remove one of the 3 drugs altogether. So it's really tailored to patients' tolerance. But I agree, the chemo myelosuppression frequency definitely increased in the 18 individuals, even though they are strong in bone marrow to start with. So this is a Kaplan-Meier survival curve, just for demonstration of that. Overall survival is 32.5 months, even though it's not statistically significant because the group size is very small. And also the progression-free survival for recurrent, this is from the recurrence, is 6.6 months for the triple chemotherapy with TTF. This is a progression-free from the recurrence. So I guess the previous one, this one is, let me see, this one should be from the, this is from the recurrence, 6.6 months. This is from the initial, I think this is probably wrong. I'm sorry, this is, I think this is, the overall survival is from the recurrence. That's right, it's from the recurrence. This is not correct. This 10.7 months is not right. So I'm sorry for this. But anyway, so the point is, using the triple chemotherapy with TTF is still possible for selective patients. And there might be a signal of improved survival, obviously not scientific enough to make a conclusion of that. But the side effects, there's no new side effects, like a severe side effects, liver damage, for example, or any other organ damage. We don't see that. But what we do see, as expected, is myelosuppression frequency and needs close follow-up. So this is an example of one of those patients received such treatment. 60-year-old male with diagnosis of GBM 2014. He is still alive as of today. So the story is, he's IDH1 wild type. And he had a first surgery 2014. He actually also participated in the EF-14 trial, but he was on the control arm. And then he switched to TTF when the interim data is reported. And then because he had a tumor progression, so in addition to the TTF, I added the triple chemotherapy, Avastin, CPT11, and he continued that for 12 cycles for the Avastin and the not 12 cycles, 12 months. So it's total of 24 treatment. But not all of them are 24. But Avastin is 24, but CPT11 is as tolerated. So it's CBC permissive. And then he continued TMZ for a total of 32 cycles because he initially received the 12 and plus this, and he wants to continue because he did not have a significant myelosuppression. So I'm pretty permissive, as you see, with the chemo, as long as patient tolerated well. And then finished March 22nd of 2017. He then continued the TTF only from March 2017 until recently. That's 3 years or 3.5 years. He had a disease progression third time. That's October of this year. And he had a surgery October 14th of this year. He did well after the third surgery. So this is the MRI. So you can see the left parietal, posterior frontal parietal. He actually have presented neurologically as with Gerstmann syndrome. This is a post-op scan, and then they have a disease progression, and then post-op again, and then this is 2014. So for many years, he'd been stable like this, and this is 2018. All this published already. So this is the flare MRIs, as most of you are familiar with. With time, there is always some flare signal expansion, and we have difficulty interpreting that due to radiation or due to tumor progression. This example, 5 years, actually have a relatively small flare expansion. So only here, and then compared to that, there is some change. But we just follow it. We just tell patients there is a change, and we could not tell them exactly this is due to tumor or due to radiation, or by my best guess, from both. So we follow that closely. So this is an enhancing scans. I'm collect them together just to show you the change over a short period of time. So this is before 2020, he was doing well like this. This is 2018. So there is minimum enhancement, but this has been stable for many, many years. But April this year, started to see this. To me, it's a suspicion of change. So I could not jump to that conclusion of tumor progression yet. So I told the patient, and then have a follow-up, close follow-up. And then, so this is 4 months later, like this. And then 2 months later, like this. So we actually decided, we have a tumor board, as you know, every week. So we decide together. So the surgeon agreed, this is most likely to be tumor progression. So he had a surgery. And then the pathology is showing as tumor progression as well. So this is a good case of close follow-up. It still is recommended, even 5 years long-term survival. But obviously, you have to tailor to the patient situation. And then, so this is the post-op, as you can see. This is pre-op, as you already saw this, with contrast and then without contrast. This is post-op with contrast and then without contrast. This is all these post-operative changes, as you see, all this. So it's a good resection by our neurosurgical colleagues. This is another patient that's actually EF-14 participant. He's still alive as well. He's from Paraguay, came to Houston to participate in this trial. He has a unique situation that he actually have 2 areas of enhancement, or 2, we call it multifocal GBM. So the posterior side of the right frontal was removed by the surgeon in Paraguay. The anterior was left untouched. So he received the radiation, and then obviously temozolomide, which is standard of care. And then he randomized to the TTF arm. So he continued that with TTF. And that actually improved over time. So the radiation, temozolomide, TTF helped significantly for the control of the even on no surgical intervention lesions or GBMs. And then so he had been stable for many years And this is 2018. Again, this paragraph also is published. Again, over time, this is 2019, as you can see, there is a new area that's enhancing on the left frontal lobe. So this one was treated with SRS, stereotactic radio surgery, gamma knife, and also there is a recurrence of the right frontal again. So was treated with gamma knife again and continued with chemotherapy in Paraguay. Unfortunately, he actually now has more tumor progression, so he cannot walk anymore. He's still alive, but cannot walk. He's wheelchair dependent. Again, the flare changes, as we talk about, over long term, there is an expansion of the flare change. I think this, as I said, is a combination of a tumor with radiation-related change. So this is the last patient I'm going to share with you. He's 28-year-old, and he gave me permission to share his pictures with you all. And so his original surgery was 2012. And the right frontal, actually bifrontal, you will see the picture next. And he had a second surgery on the left side, and then he had a third surgery on the right because due to tumor progression. And at the time, we're thinking about gamma knife, but surgery was recommended, so we did not do the gamma knife at that time. And then he also, because his CSF staging showing atypical cells, so we did an OMAYA for intrathecal chemotherapy. So he is actually wearing Optune from the EF14, and this is a post-op, so it's not the Optune. So he's wearing the Optune even when he was in the hospital. Sometimes, as you can imagine, the hospital may not give a clearance of the device for other patient safety issues. So we get a hospital engineer to clear this device with all the manufacturer information. So they clear that so he can use it in the hospital. And then the nurse obviously is always curious, what is this all about? Because they know nothing about the TTF. So he continued the treatment. And as you can see, the standard of care with the chemo radiation and then the EF14 clinical trials, he was using the TTF as he randomized the TTF arm. And then the chemo, he got a temozolomide 33 cycles as of 2015. And he also get the BEV and the TCAN. He also get a CCNU because he had a tumor progression even on here, intrathecal chemotherapy with topotecan. So he had been on observation since 2016 until March of this year. Tumor progression, and then we treated again, but did not respond. And we don't have a lot of choices anyway, as you all know. So he was on hospice, and then he passed away in May, shortly after being on hospice. So this is his MRI. Actually, sorry, this is his actual participation of activities wearing the TTF. This is a social gathering. And this is, we have a Run for the Roads fundraising events in Houston every year. So we run 5K, and then he did not run, he just walked. It's a celebration of patients with brain tumors. So we call them heroes. And so that's the activity he was there. So he wore that device as well. So this is his MRI. So this is before the surgery. I'm gonna go through this with you so you can see the clinical course. I mean the imaging during the diagnosis and treatment and the follow-up. So this is before the initial surgery. He actually was labeled, he presented with headaches, and he was labeled with ADHD for a few years and depression, was treated with all the antidepressants. Obviously, his headaches progressively worse. Eventually, he begged the physician to do a CT scan, and they did one. Then it turned to an urgency for the physician to call him to come to ER because of this massive effects. And then the flare changes, as you can see, this is all before surgery. So predominantly on the right frontal, and then there's some left frontal as well. And then obviously with massive effects with corpus callosum effacement and the compression of the ventricles. Because it's such a slow process, so he pretty much functioned normal except headaches at that time. And you can see the flare changes involving the subfrontal as well, and then even the temporal lobe. This could be edema or could be tumor. We could not tell, but that's why we call it flare changes. And this is a post-op, and then this is after the 3 operations, 2018. So he's been living like this for many, many years. He has a mild frontal lobe syndrome, but otherwise, if you see him on the street, he's normal. He's wearing the Optune, he's normal function, and he actually volunteer helping autistic kid. So this is the flare changes over the years. As you can see, all the flare changes initially we saw actually receded and diminished. And then such as here, he has a significant amount of flare change at the beginning, but at the 2018, there is no flare change we can see. So that's suggesting this either the tumor respond to treatment or the edema that's responded with treatment. But unfortunately, with subsequent follow-up, the enhancement is actually very minimum or none, but the flare change start to expand. And this is 2019. And this is 2017. And then you can see this is actually minimum. And then later on, 2019, he started to expand. So this is 2017, 2019. You can see the flare changes expand. And this is before his obvious tumor progression clinically. The enhancement scan is actually still stable, but the flare changes, that's very much infiltrative, including this, even the brainstem. So he actually developed a clinical decline in terms of the weakness of the legs and the memory decline, worsening of his frontal lobe syndrome. Because we tried everything we can, and then the family decided hospice, so he expired in May of 2020, unfortunately. So let's talk about the side effects of TTF. As we said, it's really the skin irritation. Usually it's reversible. Sometimes they can be really bad, causing an ulcer, so it requires a long-term off of the TTF to recover. So this is the example of the rash of the scalp due to the, this is actually allergic to some degree for this patient, to the either the gel or the array, I think it's yeah, so the material. So we give them the antihistamine, and sometimes we had to give them prednisone to reduce that reaction. And this is another two patients separate situation of the contact dermatitis. And this particular patient is very unique. It's the first time I saw that. I want to share with you. It's like a subcutaneous hemorrhage. I'm following this patient right now. I asked her to take this off for a few days. This is actually panel of 6. It's published. As you can see, the reaction to the arrays. And then this particular patient that removed the array so fast to minimize pain theoretically, but causing a tear of the scalp. So that's the healing part of that. And then this is the other patient have this incision part that did not heal quickly. So we still able to use the Optune, but avoid that area. Obviously cannot follow the array map as religiously as we would like, but that's okay. It's better than nothing if they can still use it. And then this patient, that's what we're talking about, this 28-year-old, the last patient I showed you. He has bifrontal disease. He has bifrontal surgery, as you can see. Because he used this for 5 years and 6 years, and he has a significant atrophy. So the screws from the surgery is showing up because of soft tissue atrophy. So he actually has to do a plastic surgery in order to continue to use the Optune. Otherwise, this part of the skin would be broken. We actually did that. So he was able to continue to use Optune. That's another example of extensive usage of Optune causing the atrophy, or maybe because he had too many surgeries, he's going to have atrophy anyway. But my gut feeling is it's probably a combination of both. And as we all know, most of our patients not lucky enough to live this long, so we don't see the consequences of this. But I want to share that with you so you kind of be aware of. And then this is a unique situation that some of the patients have craniectomy because they have infection, so their bone is removed and cannot be used. Because this area of the craniectomy is pretty small, so the patient is wearing helmets when they are going outside, but at home she just like this. So we can still use the Optune in this setting. Obviously not FDA approved, but I want to share that with you that it can still be possible like this. So we obviously cannot follow the array map 100% either. I try to work around it. So this is the situation I'm going to share with you. So the treatment for those dermatitis and ulcers is pretty routine, using the steroids or antibiotics or rest. And I have a few patients that requires plastic surgery to fix those ulcers that's not healing. So that's my last resort. In general, I let patient rest, and then they with steroids or antihistamines or prednisones, if they are allergic to that, or antibiotics. Most of those, 99% of them heals with such an intervention. Okay, in summary, TTF is an effective, novel, portable, regional GBM therapeutic modality. It's a new option we use for GBM therapy. And there are few side effects, mostly the scalp irritation only, which is reversible, or mostly reversible and with intervention of creams, antibiotics, or rest, or in the extreme situation, we may need a plastic surgery to help. And in terms of the future, I expect combination of TTF with other chemotherapy options or targeted drug therapies or immunotherapies holds promise for more effective therapies of GBM. Thank you very much. I want to thank patients and my colleagues for working together, taking care of patients as a team. Thank you all for your attention. I'm going to take questions.